Herpes zoster is caused by the reactivation of the varicella zoster virus, and it is characterized by a painful erythematous rash in the affected dermatome. About 20 to 30% of the people with herpes zoster develop during their lifetime, and the incidence of herpes zoster infection increases when there is a decrease in the cell-mediated immunity. So it is the segmental eruption of the herpetiform vesicles on the skin affecting unilateral dermatomes, and between 50 to 65 years of age. The most common dermatome which is involved is the thoracic one, which is 53% of cases. Cervical is 20%, lumbosacral is 11%, trigeminal is 15%, while there is a rare involvement bilaterally. 75% of the patient with herpes zoster experience prodromal symptoms including pain, fever, and headache, which usually begins few days before the rash onset. Now, there are certain terminologies such as acute herpetic neuralgia, which is defined as a pain which occurs within the month of the rash appearance. Subacute herpetic neuralgia, which persists 30 to 90 days, and post-herpetic neuralgia, which persists beyond 3 months after the rash appearance. Regarding the risk factors for post-herpetic neuralgia, age greater than 60 years of age, those patients who have a decreased cell-mediated immunity, for example, diabetic patients, patients of cancer with chemotherapy, if there is a severe, intense, widespread rash, delayed start of the antiviral treatment, which is after 72 hours of the rash onset, increased incidence is found in the female gender, and those patients who have ophthalmic V1 involvement and dermatomes T1 to T6 is an increased risk factor for development of post-herpetic neuralgia. Now, there are certain postmortem histological studies which shows that in those patients who have with and without pain, there is loss of myelin with fibrosis. But those patients which have persistent pain, there is not only loss of myelin, along with fibrosis and atrophy at the level of dorsal root ganglion. The pathophysiology behind post-herpetic neuralgia is sensitization and deafferentation. Sensitization means increased heightened response to a neural damage with multiple ectopic discharges, resulting in allodynia and hyperalgesia, and deafferentation pain with loss of sensory input from the damaged nerve fibers. So what happens when this virus gets latent in the DRG? It produces an inflammatory cascade resulting in dysfunction of that DRG, and there is loss of sensory input. But at the same time, there is increased ectopic discharge from these damaged neurons, which cause increased expression of sodium and glutamate, resulting in progression of acute zoster pain to the post-herpetic neuralgia. Now, this is a comprehensive algorithm management of the neuropathic pain. Once we have various screening tools to confirm whether it's a neuropathic pain or not, which include DNR4 questionnaire, pain detect, and leads assessment of neuropathic sign and symptoms. What it is confirmed that it's a neuropathic pain, then initially we give the trial of the gabapentniods, TCAs, SNRIs, along with the topical agent for the initial 4 to 6 weeks period. Then we assess the patient. But after 4 to 6 weeks, if it is not involved with this pharmacological treatment, we either combine the treatment along with the low dose tramadol. If it is again not relieved, then the next option will be the interventional therapies in the form of blocks, in the form of DRG injections. And if it is not involved, then we go for neuromodulation, low dose opioids, and intrathecal, which is the targeted drug delivery. Again, the management of post-herpetic neuralgia, the first line is the topical agents along with the anticonvulsants. If it is not relieved, then the second line will be opioids. And in case of refractory pain, spinal cord stimulator or intrathecal steroids injection. The role of peripheral nerve blocks in the management of post-herpetic neuralgia is both diagnostic as well as prognostic, and they are commonly performed in the trunk with local anesthetic and steroids. And the benefit of adding local anesthetic gives the information of the exact pain generator from where the pain is arising. On the right-hand side, you can see the image of the fluoroscopy guided intercostal nerve block. The role of erector spiny plane block in the management of post-herpetic neuralgia has a promising result. As you can see on the right-hand side, this is a study from 2021, which says that erector spiny plane block at 12 weeks after the lesions, they reduces not only the neuropathic pain, but also improves sleep and decreases the chances of anxiety and depression, both at rest and at movement. Similar is the role of thoracic paravertebral nerve blocks and intercostal nerve blocks because the pleura are in the close vicinity of these blocks and carries a high risk of pneumothorax. So performance of these blocks under ultrasound guidance is mandatory. This slide shows the role of pulse radiofrequency in the management of post-herpetic neuralgia. This is a study by Dr. Kim in 2017, and they divided the patients into two groups. One group of patients received pulse radiofrequency in the early 90 days after the development of post-herpetic neuralgia, and the other group received pulse radiofrequency after 90 days. So as you can see from the graph that those patients which were given pulse radiofrequency in the early 90 days of the post-herpetic neuralgia showed a better pain relief and reduces the chances of complications. So the conclusion from this study was that pulse radiofrequency is more effective when it is applied in the early stage of the disease. This is the update on the clinical management of post-herpetic neuralgia on the basis of mechanism-based treatment. So we divided the pain of post-herpetic neuralgia into three types: sensory loss, thermal, and mechanical hyperalgesia. Sensory loss is the deafferentation pain, which is the loss of small and the large nerve fibers, and it's basically an abnormal ectopic discharges at the level of nociception, that is the DRG. While in case of thermal hyperalgesia, the patient becomes sensitive to heat and cold, and there is increased ongoing hyperactivity in the surviving nociceptors. Whereas in case of mechanical hyperalgesia, the patient has increased response to blunt and the pinprick stimuli, which suggest a heightened central sensitization. So based on this classification and the cohort study, we divided the management that if it is a mechanical hyperalgesia, means that the sensitization is at the level of the second order neurons, then the management include initially the pharmacological and the topical therapy in the form of 5% lidocaine patch and capsaicin cream. And if it is not relieved, then interventions plays an important role such as intercostal nerve blocks, paravertebral nerve blocks, erector spiny plane blocks, or epidural, which may be interlaminar or transforaminal. And if it is not relieved, then it will be a diagnostic fluoroscopy guided DRG injection followed by pulse radiofrequency. But if it is not relieved even after pulse radiofrequency, then the next option will be DRG stimulation or spinal cord stimulation. If it's a sensory loss or a deafferentation pain, then initially we target the systemic therapy targeting the GABA receptors and the dopamine receptors. But because it's a sensory loss, so the role of the already the damage has been done by the varicella zoster virus at the level of the DRG, then the next option will be to go for a diagnostic DRG injection block under fluoroscopy followed by pulse radiofrequency, and in case of refractory pain, DRG stimulation or spinal cord stimulation. This is a case-based interventional management of the lumbar post-herpetic neuralgia. This is a 57-year-old male presented in our clinic. And as you can see, the multiple lesions involving the L5 dermatome, showing the red arrows involving the dorsum of the foot. So initially we started this patient on gabapentniods, TCAs, and the topical agents for the initial 2 weeks, but there was no significant pain relief. So we decided to give him erector spiny pain block with local anesthetic and steroid, which gave him about 60% pain relief. But again, after 3 weeks, the patient presented with the similar complaints, and we decided to give an interlaminar lumbar epidural steroid injections which provided him 100% pain relief at the moment. But again, at 6 weeks, the patient presented with similar complaint. So we decided to do a fluoroscopy guided diagnostic DRG block followed by pulse radiofrequency, which provided him almost 70% pain relief. And we followed this patient every month for the consecutive 3 months. Summarizing post-herpetic neuralgia, it's a chronic debilitating neuropathic pain condition following herpes zoster, leading to physical, psychological, and social impairment. The first line agents are the pharmacological options along with the topical therapies. The preventive strategies, the most important is the vaccination, which is effective in the elderly and those patients who are immunosuppressed. And antiviral therapy, early use of antiviral therapy in the acute phase reduces the risk of post-herpetic neuralgia. So timely evidence-based interventions improve the outcome in post-herpetic neuralgia. This is the strength of evidence from 2020 regarding various interventions roles in the management of post-herpetic neuralgia. As you can see, there is moderate evidence for the pulse radiofrequency for intercostal and the DRG, as well as if there is involvement of the cervical region, then stellate ganglion block radiofrequency, while the evidence of the other interventions, including epidural, intercostal, chemical neurolysis, and spinal cord stimulator, are low. My second topic of my presentation is diabetic neuropathy. And diabetic neuropathy is the most prevalent chronic complications of both type 1 and type 2 diabetics. And more than 50% of all diabetic patients, they have suffered from diabetic neuropathy. It starts with the small fibers involvement, leading to burning sensation and pain, and then it ascends upward, resulting in numbness and proprioceptive loss. So the symptoms begin in the foot and they ascend in the distal to proximal pattern. So what happens during obesity and insulin resistance when there is a hyperglycemia? It leads to bioenergetic failure and increased load on the mitochondria, which are the energy producing cells in our body, leading to inflammation and apoptosis. On the other hand, there is release of the reactive oxygen free radicals, which also disturb the mitochondrial traffic, increased load on the endoplasmic reticulum, resulting in axonal failure. Regarding risk factors for diabetic neuropathy and painful diabetic neuropathy, it is a lifestyle changes, advanced age, metabolic syndrome, uncontrolled blood sugar level. While in case of painful diabetic neuropathy, patient with already having neuropathy, increased BMI, and increased already renal dysfunction plus genetics are the risk factors for the development of painful diabetic neuropathy. The risk factors include poor glycemic control, long duration of diabetes, increased age, hypertension, along with comorbidities such as metabolic syndrome. And if it is an involvement of the large fibers, this will result in imbalance, weakness, increased risk of fall, and a huge impact on the gait and balance. Regarding classification of the diabetic neuropathy, it is divided into two types. The most common one, which is 50%, is the classical glove and stocking distribution, which is a distal symmetrical polyneuropathy. The second one is the autonomic neuropathy, which affect the gut, heart, and the bladder, which is 20 to 40%. If it involve a single nerve, then it is mononeuropathy. And if it involve a nerve along the radicular pattern, this is radiculoplexus neuropathy. If it involves a small fiber, patient presents with burning, tingling, shooting, electric shock-like sensation, and the signs are allodynia, hyperalgesia, and dysesthesia. And these are not detected on the conventional nerve conduction studies. And in small fiber involvement, the reflexes are usually normal. But if the large fiber are involved in diabetic neuropathy, not only the numbness and tingling sensation, there is poor balance resulting in weakness, unsteadiness, and increased risk of fall. And the patient describes as the feet feel wrapped in the wool, or if the patient is walking on the thick socks. This is a summarization of the involvement of the small and the large nerve fibers. If the small fibers are involved, burning, tingling sensations. If large fibers are involved, patient has difficulty in balance, increased risk of fall. And to test the small fibers, there are thermal discrimination and pinprick sensations, whereas if the large fibers are involved, we will check it by the qualitative sensory testing, which include the monofilament testing, proprioception, and please remember, if the large fibers are involved, the anchor reflexes will be reduced or may be absent. So how to approach a patient with diabetic neuropathy? First, we take a targeted history, such as what is the control of diabetes, what is the duration of diabetes, is there any metabolic syndromes or other comorbidities present or not. Then we classify the patient according to the fibers, if it is a small fiber involvement or if it is a large fiber involvement. If it's a large fiber involvement, the reflexes, particularly in the foot, the anchor reflexes will be reduced or may be absent, but in case of small fibers, it will be intact. And if it is a classical glove and stocking distribution, means the diabetic polyneuropathy is present. And if it presents with atypical symptoms, which may involve a multidisciplinary approach involving neurologist. Can diabetic patients, maybe diabetic neuropathy can be asymptomatic? Yes, up to 50% of the patient with diabetic neuropathy may be asymptomatic. Other may lose the awareness of symptoms and they are discovered incidentally during the routine examination. In advanced cases, there is loss of sensation resulting in complete numb foot, so increased risk of painless injuries, foot ulcers, and amputation. So the loss of gift of pain leads to unnoticeable injuries and worsening complications. Regarding the assessment of the small fiber testing, pinprick and the temperature sensation, whereas the large fiber testing, it is the classical tuning fork method, monofilament testing, and the rules of the examination are you will start with the distal end and then move proximally. First, you test the normal side and then the abnormal side, and you perform the examination always bilaterally and symmetrically. There are various screening tools to assess diabetic neuropathy, such as Toronto Clinical Neuropathy Score, Neuropathy Disability Score, Michigan Neuropathy Screening Instrument, and McGill Pain Questionnaire or DNR-4 questionnaire. We routinely use the Michigan Neuropathy Screening Instrument score, and based on these four symptoms, we classify the patient whether it's a diabetic neuropathy or not. For example, if a patient has an abnormal appearance, dry with fissures on the foot, ulcers are present, anchor reflexes only with reinforcement or may be absent. So if the more than two of these parameters are present, it is indicative of neuropathy. This test has a sensitivity of 65%, whereas specificity of 83%. This is a non-invasive imaging technique which is called corneal confocal microscopy, which can detect diabetic polyneuropathy even before the symptoms have arrived. And it's a non-invasive test. It's basically tests the corneal fiber plexus, the number of fibers, their density, and their length, and it allows early detection of diabetic neuropathy. So as you can see on the right-hand side, you can see in the figure A, there is a lot of the fibers, dense, thick fibers, but as the disease progresses, the fiber get reduced, their thickness get reduced, and their length can reduce, suggesting of these various stages of the diabetic polyneuropathy. Differential diagnoses include metabolic syndromes, systemic disorders, inflammatory disorders, nutritional deficiencies such as vitamin B12, B6, B1, and patients on chemotherapy and patients who have intake of alcohol. So the recommendations from the American Diabetic Association is that the patients of type 2 diabetes, they should be annually assessed for diabetic polyneuropathy. And in case of type 1 diabetes, the assessment should be done every 5 years. It should be a detailed history and at least two sensation and reflexes must be tested. Electrophysiological testing is rarely needed for the patients with typical signs and symptoms, but in case of complex differential or atypical symptoms, required a multidisciplinary team approach involving neurologist or further additional testing. Regarding the management of diabetic polyneuropathy, we first start with the non-pharmacological therapies such as exercise, dietary modifications. Pharmacological therapy include the TCAs, gabapentniods. The drug of choice by the FDA in diabetic polyneuropathy is duloxetine along with the topical therapy. But the use of opioid is discouraged in diabetic polyneuropathy because of the risk of addiction, tolerance, and dependence. This is a mechanism-based treatment of diabetic polyneuropathy, such as methylcobalamin, which promotes nerve regeneration and axonal growth, alpha-lipoic acid, which decreases the release of the oxygen-free radicals, aldose reductase inhibitors prevent the sorbitol accumulation, pentoxifylline, which improve the circulation, and N-acetylcysteine, which improve mitochondrial trafficking. The treatment options for painful diabetic polyneuropathy, the first-line agents are pregabalin and gabapentin. But pregabalin is usually preferred because it has a fast onset. It allows easy titration as compared to the gabapentin, which require twice or three time dosing. The drug of choice in diabetic polyneuropathy is duloxetine, but it carries a high risk of nausea. Sodium channel inhibitors such as carbamazepine and oxcarbamazepine are used in the treatment of diabetic polyneuropathy. Similar is for the tricyclic antidepressants such as amitriptyline and nortriptyline, but they have anticholinergic side effects, particularly in the elderly populations. Although opioids are discouraged in the management of diabetic polyneuropathy, but only in the refractory cases when the pain is not controlled, we can add low-dose tramadol or tapentadol. And similar is the role of lidocaine 5% patch and capsaicin 8% patch. This is a study which is showing that increasing the dose of pregabalin, as you increase the dose of pregabalin, better is the pain relief. So starting from 150, 300 to 600, as you can see on the graph, as you increase the dose of pregabalin, better is the pain relief. This is a study comparing duloxetine 60 milligram versus 300 milligram of pregabalin. As you can see from the graph, at 4 weeks and 8 weeks of the development of diabetic polyneuropathy, duloxetine 60 milligram provide a promising result in decreasing the pain at 4 weeks and at 8 weeks. Now, this is a very interesting study, and it is basically called the combo DN study comparing duloxetine versus pregabalin in combination or high dose monotherapy of either duloxetine versus pregabalin in the management of painful diabetic neuropathy. So they decided to divide the patients on the initial 8-week period and they compared duloxetine 60 milligram with 300 milligram of pregabalin. So what they have found that duloxetine at 4 weeks and at 8 weeks, they reduces the pain in diabetic neuropathy. But those patients in the initial 8 weeks period, but those patients who have not responded or who have less than 30% pain response, then they entered these patients into a more intensive phase where they combined this 60 milligram of duloxetine with 300 milligram of pregabalin and they compared it with those patients who were given high dose of monotherapy of duloxetine up to 120 milligram and pregabalin up to 600 milligram. So what they found that the combination therapy is not superior to the high dose monotherapy. So the conclusion of that study was that duloxetine 60 milligram is more effective than pregabalin in the initial 8 weeks period. But after that, if the pain is not relieved, either you combine the duloxetine 60 milligram with 300 milligram or you increase the dose of pregabalin, they have the similar effect. Here is a meta-analysis from this study. The vertical line shows the mean effect, and on the left-hand side are the in favor of duloxetine. So basically, they use the brief pain inventory index score. And you can see here in favor of duloxetine, not only it improves the pain, it improves the mood, it improves the sleep and the quality of life. But on the right-hand side, when they compared the combined effect of pregabalin and duloxetine versus high-dose monotherapy, they have almost the similar effect. So the conclusion was that the duloxetine provide a superior efficacy in the initial period, but after that, we can either combine the duloxetine with pregabalin, or you can individually increase the dose of either duloxetine or pregabalin. They have almost a similar effect. So combination therapy is used in mild to moderate pain, whereas high dose monotherapy is used when it is not controlled. This is a graph which is showing various doses of pregabalin and duloxetine. As you can see, increasing the dose of pregabalin from starting from 75 and 150 up to 600, increasing the dose better is the pain relief. But in case of duloxetine, if we use once a day or if we use twice a day up to 120 milligram, they have almost a similar effect. So in case of duloxetine, 60 milligram duloxetine provides a similar effect as compared to 120 milligram of duloxetine. This is a slide summarizing my presentation that the prevention is the key. And in case of type 1 diabetics, tight glycemic control is required. But in case of type 2 diabetics, although it has a favorable effect on the pain and reduces the chances of amputation, but already the damage has been done and these patients are incidentally diagnosed, particularly in type 2 diabetes. So the tight glycemic control do have a vital role, but limited efficacy in diabetic neuropathy. Next is the lifestyle modifications. Mechanism-based treatment include neuroprotective agents, as we have discussed earlier, methylcobalamin, alpha-lipoic acid, microcirculation enhancers. The pharmacological treatment, the first line is pregabalin and gabapentin, duloxetine, carbamazepine, and amitriptyline. If the first line therapy fails, then you can add a second line in the form of topical and in the form of opioids. The non-pharmacological techniques include acupuncture, spinal cord stimulation, and TENS. So the conclusion, the recommendations from the American Diabetic Association, NICE guidelines, and the Combo DN study, pregabalin 150 to 600 milligram randomized control trial provides effective pain relief and improves sleep. 60 milligram of duloxetine has analgesic and mood benefit effects. TCAs are used in the elderly population. TCAs are used in the treatment, but it should be used cautiously in elderly population because of its anticholinergic side effects. But in case of refractory cases, tramadol and tapentadol can be used. Topical agents are used for localized pain in diabetic neuropathy, such as 8% capsaicin patch or lidocaine patch. The combination therapy, duloxetine and pregabalin versus high-dose monotherapy shows similar efficacy, and it should be considered when monotherapy is insufficient or the patient is having side effects from increasing the dose of monotherapy. Thank you.
Well done, Wasim. Mashallah, very well presented.
Thank you, madam. Thank you, Dr. Wasim. We now welcome the audience to ask questions, please, or they can even write in the comment box.
Faccio ringraziare, come faccio a ringraziare? Thank you. Thank you all. TH. Thank you all.
Dr. Wasim, we have a question in the chat box. Everybody is prescribing low dose gabapentin and few duloxetine. How low dose can affect your management?
I think the starting dose should be 150 milligram, and we have seen in the various studies that increasing the dose from 150 to 300 will provide a better pain relief, but you have to tailor it according to the patient phenotype. If it's having side effects from pregabalin such as sedation, somnolence, weight gain, or peripheral edema, you can either combine with the other drugs.
Okay. In the chat box, we have, can you please explain about serotonin syndrome?
Serotonin syndrome, basically, it's very similar to our famous disease such as malignant hyperthermia, such as increased heart rate, muscle rigidity. And it's basically combining these SSRIs along with the tramadol and the TCAs. And patient is increased risk of, I think, developing arrhythmias.
Okay, any more questions, please, from the audience?
Is there a risk of serotonin syndrome with SNRIs also? SNRI and tramadol?
Sir, I've seen with the tramadol, but with SSRIs, not with the SNRIs. The opiates are basically used as the second line agent. If it is not controlled with the primary, the pharmacological treatment, then we can use opiate as a second line, not at the first line. And we can use it at a very low dose.
Dr. Wasim, we have another question in the chat box. What are the key points we should cover when counseling a patient newly diagnosed with post-herpetic neuralgia? How do we explain the chronic nature of post-herpetic neuralgia to patients without causing distress or loss of hope? And what are the best strategies to educate patients about realistic expectations from pharmacological treatments?
Thank you, Dr. Sadia. As a very important question that most of the patient with post-herpetic neuralgia, it's very difficult to treat. So we have to explain the patients that approximately if we achieve successful 40% pain relief, that is a huge success for us. And most of these patients are referred from the dermatology department. And if we control the acute phase of the herpes zoster, either with the pharmacological treatment or with the interventions, we can prevent the development of the post-herpetic neuralgia. And the treating the acute pain in the acute phase of the herpes zoster, I think it will prevent the development of post-herpetic neuralgia and reduces complications.
Thank you. What do you think about cannabis treatment in neuropathy in diabetes?
Mm, sorry, I don't have any experience about using cannabis. I think
We
it's
have
not
not
available in
used cannabis
Pakistan.
in our center. I'll just add to it, Sadia, Dr. Lina here, that
Sure,
the
ma'am. Sure,
treatment
ma'am.
cannabis is not much with the center, and I think it is mostly a little experimental in different centers here in Pakistan as well. I can't say what are they doing abroad.
Assalamu alaikum. This is Dr. Waqas here from Gurki Trust Teaching Hospital. Well, cannabis acts on CB1 and CB2 receptors, and still there are research going on whether it modulates and it is effective for the neuropathic pain or not. It is more effective for the nociceptive pain. If there is a mixed type of pain, which is a neuropathic and the nociceptive as well, then the cannabis can have a role. Otherwise, simply purely solely in the neuropathic, it has so far no evidence of that.
Thank you, Dr. Wakas. Thank you so much. Thank you, Dr. Lina. Do we have any more questions from the audience?
Let me add a little. In Aga Khan, they are experimenting on cannabis currently. And let's see what results we have, because surely they are not prescribing it at the moment.
Thank you, madam. Thank you, Dr. Wasim, for very precise yet evidence-based presentation. Thank you to all the audience who
Thank you,
took
Dr.
out.
Sadia.
Thank you, everyone. So we will wait for the next presentation schedule, inshallah. Thank you so much. Khuda Hafiz.
वाह, मेरे चीते ने बहुत अच्छा प्रेजेंट किया है। चुप करा दिया सारे को। Well done.